So we're honored to welcome the outstanding team from the NYU Langone Center for Neuromodulation. So I'd like to introduce the doctors. Dr. Dennis is here now, and he'll be speaking first. And Dr. Alain Mogliner is coming soon, but I'll introduce him now. Okay, so Dr. Alain Mogliner is a nationally recognized neurosurgeon and director of the Center for Neuromodulation at NYU Langone. He's a leader in functional neurosurgery. He specializes in advanced treatments for Parkinson's, including deep brain stimulation. Having performed thousands of procedures, he is known for combining technical precision with a deeply patient-centered approach, focusing on improving both symptoms and overall quality of life. We met Dr. Dennis London, I think, when we had a dinner and we really got to know him and got to appreciate him, and we're very grateful that he's here. He's a highly experienced neurologist specializing in movement disorders with a strong focus on Parkinson's. He's known for his thoughtful, individualized care and for helping patients and families navigate complex treatment decisions. We also want to acknowledge that Dr. Michael Porfar, who unfortunately could not be with us tonight, but he is an important part of the team. Let's recognize our volunteers. I couldn't do this without them. Sam Amdurer, Charlene Rubenstein, and Sarah DeVere are here tonight, so thank you for your dedication and your heart. You'll learn tonight how the brain works under the strain of Parkinson's, what affects memory and decision-making, and how advanced treatments like deep brain stimulation and high-intensity focused ultrasound are reshaping care. Most important, this is not just a lecture. This is a conversation, and we want you to bring your questions, stay curious, and take full advantage of this opportunity because Dr. Dennis London came all the way from the city, and same with Dr. Mogliner, and so get ready for an evening of insight and empowerment. So please welcome Dr. London.
Sounds good. All right. Thank you very much, Susan, for inviting me here, for hosting this event. Thank you to our sponsors, to Ashley and everyone else for making this possible, and thank you to all of you for being here. We put our slides up as well. Yeah. They're not essential, but might as well use them.
You don't like those mountains behind you?
Probably better for everyone's mental health. So as Susan said, my name is Dennis London. I'm actually a neurosurgeon. That's okay. But I'm also a neuroscientist and a researcher, and I study how Parkinson's is involved in not just movement, but how it also affects cognition and how those two things coexist and interplay. What I'll be talking about today is, I think, an underappreciated, at least in the medical community, part of Parkinson's disease, and that is, we look at Parkinson's and we think of tremor primarily, but also slowness of movements and freezing of gait. But what I'll be talking to you about today more is about how Parkinson's affects cognition, how the things that we do medically play into that, and then what everyone here can do to improve their thinking, to have clearer thinking. Okay. So the thinking changes in Parkinson's are often under the surface, but they tend to be what affects people more. So both what patients notice, but also what spouses and children notice first. And the more kind of cognitive symptoms people have, that really is what adds to the burden, frequently more than the tremor itself or than the bradykinesia. Okay, and so today what I'll talk with you about is what exactly is the cognitive profile of Parkinson's disease. It has a very specific kind of flavor to it, and that also affects what we can do to treat it. We can go to the next slide. So I think I'll start with an example that I think probably most of you can relate to about what are the cognitive changes in Parkinson's disease. And the cognitive changes in Parkinson's, they're not Alzheimer's. They're very distinct from Alzheimer's. They're not really changes in memory. They're not losing your memories. They're not the ability to form new memories. They they're distinct from that. And where it all stems from is what biologically is happening in Parkinson's, which is a loss of neurons that make dopamine, which is a neurotransmitter that the most of kind of the public thinks of as being involved in movement, because when we give patients dopamine, they tend to move better. But it's involved in a lot more than that. It's involved in reward, so understanding when things are positive and reacting to things that are positive and doing them again. It's involved in motivation and understanding what to do and what not to do. And when there's a loss of dopamine, and then conversely, when we give dopamine back to people, we are affecting not just movement, we are affecting all of those things. So imagine that you're at a party or at a gathering like this one, and you are walking and talking with a friend, and you are doing two things at the same time at least. Most of us are probably doing more than two things at any particular point of the day. And we have to juggle them, and we have to do them and not let them interfere with one another. And to some extent, that tension exists all the time in everyone. And the more we do one thing, the worse we are doing the other thing. That's true in general. But this ability that we have to multitask, it worsens in Parkinson's disease. And so it's not that you lose each individual ability like walking or talking. It's that when they are both happening at the same time, your ability to maintain them and prevent them from interfering with one another, that's what gets affected. Another thing that gets affected is fluency. So it's not that you've lost words, that you've lost what a word means, or you've lost the words themselves. It's that the words are on the tip of your tongue and you can't quite find them in the right moment, especially when you're doing other things. And then the final thing is, imagine that you are talking with your partner at this gathering. You're walking. You're trying to avoid hitting and running into the person that's to your side, and then someone calls out to you from across the room. You have to switch gears, and that switching gears is what psychologists call set shifting. You have to stop midstream the conversation that you're having. You have to potentially stop walking in the direction that you were walking. You have to turn your head. And then you have to interpret what the other person is saying in the context of a conversation that maybe was unrelated, and then come up with an appropriate response. That is something that's probably not easy to do in the best of circumstances, especially in a crowded room with a lot of noise. But doing it when the dopamine circuit in Parkinson's is affected is even harder. So these are kind of the broad things that are affected in Parkinson's. They're not, the loss of memories, the loss of abilities. They're putting the right ability, having it active at the right point in time, and then changing it and being flexible in kind of what we're doing. So this kind of broad picture is what we would call executive function. And that's really where the cognitive changes in Parkinson's originate. Okay, we can go to the next slide. Okay. Now, in addition to executive function and cognitive function, we can go to one more slide, are a number of other hidden symptoms. So we talked about cognitive flexibility, but the other symptoms are related to mood. So depression is present in more than a third of Parkinson's patients. And depression is not just being sad. It's also involving loss of motivation, not doing things that you normally find enjoyment because you no longer find enjoyment in them. Another big feature of depression is slowness of movement. People who are depressed, they move slower. But this probably sounds familiar to people in this room because it's one of the cardinal symptoms of Parkinson's disease, which, as you can imagine, makes it hard to distinguish. Does this person who has Parkinson's disease, are they also depressed? The symptoms overlap. It may be very hard to tell the difference. And as you can imagine, it's underdiagnosed as a result. The flip side of depression is anxiety. So patients, when they are on their medication, when the medication is working well, often feel very good. But when the medication wears off, in addition to moving slower, there is a sense of anxiety that often comes along with it. And then the final thing is a symptom that I think people often don't think of as a symptom, which is apathy, which is kind of losing the motivation to do things. And it can be misinterpreted as laziness, but that's not what it is. It's a loss of that same motivation circuitry that dopamine affects. And recognizing all these things is important because they are treatable. They're not all necessarily true with medication. I mean, depression is to some extent, but the others are not, and there are other things that treat them better than medication. That's what we'll talk about today. We can go to the next slide. So the flip side of apathy, which is losing the motivation to do things, is doing things that are inappropriate or picking the inappropriate action for a particular moment. So, if we are in our closet and we notice that our shirt has a hole in it, we should go online or go to the store and buy a new shirt. But doing those things all the time inappropriately you might call that compulsive shopping, or maybe not shopping, maybe gambling. And to some extent, these things can happen in a regular person. They can happen with Parkinson's by itself. But a lot of our treatments for Parkinson's make these things worse. So if you imagine that dopamine is involved in movement, but it also is involved in motivation, if we give somebody back dopamine on a schedule, we make them move better, but we also might give them motivation at inappropriate times. And if we do too much of that, they might be motivated to do things that don't really make sense, like buy another shirt when you already have 20 that are perfectly good, and do that over and over again. And so that might be, to some extent, responsible for compulsive shopping. And these things are dose-related and they're medication-related. So it's not every medication, it's some more than others. For example, dopamine agonists, not levodopa, are associated with impulse control disorders. So all the things that you see on this slide. And to some extent, they can be treated by changing medication or reducing medication. We can go next slide. And we can go a little bit into medications, though it's not the focus of this talk. So dopamine agonists are effective for treating the movement symptoms of Parkinson's, but they can make impulse control disorders worse. Not that they do it in everyone, and they don't even do it in most people, but sometimes it happens, and it's important to recognize that it's a medication effect and not a personality disorder and not a character flaw. Levodopa or Sinemet usually is relatively well tolerated from a cognitive perspective, and in fact, it often makes cognition better at the right dose. When patients are on, they often report that they think more clearly. But when the dose gets too high, it can induce the same impulsive disorders as dopamine agonists, and they can also both cause hallucinations. And these things are dose related. If you go down on the dose, you can affect them. I've just told you a bunch of ways we can make thinking worse in Parkinson's disease. So you're probably thinking, how can we make it better? Medication-wise, there's honestly not that much, which is why I won't spend that much time on it. There's a medicine called rivastigmine, which is really from the Alzheimer's world that has been ported over to Parkinson's disease, and it moves the needle a little bit, but it's not dramatically effective, and it has some side effects. But it is out there, and it's approved for treating dementia in Parkinson's disease. But again, this is not the major thing that affects cognition in Parkinson's disease. And what is really effective, what there's a lot of data for, what really has very few side effects, we can go to the next slide, is not a pill. We can go one more slide. It's actually very simple, which is exercise. I mean, I hate to be obvious about it, but the data is incredibly strong. There's a lot of unproven things out there. This is proven by numerous studies. It's probably obvious to say that exercise in Parkinson's disease, or in general, improves movement. It's nice to see this proven, but it's kind of obvious. But it also improves thinking, which is not necessarily obvious. So really, not all movement, not all exercise is created equal, but high intensity aerobic activity like cycling, done regularly, improves movement, but it also improves thinking. Cycling is not the only one. Boxing, and a lot of people here are probably familiar with rock-steady boxing, has a lot of good data behind it. And probably the reason that these things work to a large degree is that they practice those same sort of executive function skills that Parkinson's affects. So cycling practices movement, but rock-steady boxing has a lot more than movement to it. You have to change what you were doing all the time, change from one movement to the next. be flexible in what you're doing, react to your partner. These are kind of the things that Parkinson's affects itself. Another one is dance. Dance, and specific tango, I think, has been the one that's probably the most studied. You have a partner. You have to pick the right movement at the right time, react to your partner, and do that all on your feet while breaking a sweat. And that practices those same skills that are part of executive function. I'll point out that all of these things are things that the Parkinson's Wellness Project is involved in heavily, and you can go into this website, parkinsonswellnessproject.org/workout, to look at a sampling of classes that are of this flavor, in addition to rock steady boxing and physical therapy. There's also PD on the Move, which is a program that basically combines features of dance and boxing and a number of other things to really work on kind of the whole picture. I'm going to highlight, this is really the only scientific study I'm going to directly mention here, but I think the evidence for it is really good. This is a randomized trial where they took over 100 patients with Parkinson's disease and randomized them to do 30 minutes of high-intensity cycling 3 times a week for 6 months, and then the other half were randomized to do stretching. So they were all doing something. And then they tested patients. They tested movement, but I won't focus on that. They also tested their cognition. So they had patients do a very simple task where they had to look at a screen and look at a cursor, and then sometimes they had to look away from the cursor, which is kind of an unnatural thing to do. And it requires switching what you are doing, having cognitive flexibility. And patients who did the cycling for 6 months did a lot better on that than patients who did the stretching. They did a further thing, and that's to look at brain atrophy. Brain atrophy is something that unfortunately all of us get. As we get older, the brain tends to shrink. This probably has something to do with how the thinking process changes as we get older. And brain atrophy happens slower in patients who were on the regular cycling program. Actually, over the 6-month period of the study, the brain atrophy was not really measurable in those patients, and it was a little bit measurable in the other group. So exercise affects not just movement and thinking, but it also potentially can slow the cognitive changes that happen with age and with Parkinson's disease itself. Okay. And now I'll switch gears a little bit and talk about brain stimulation and how that affects movement and cognition. The first thing that I'll talk about, we can go to the next slide, is a non-invasive treatment. This is not Parkinson's specific by any means. This is transcranial magnetic stimulation, which is a non-invasive way to stimulate the brain that's been studied for a whole host of different things, including Parkinson's specifically. But the thing that it really works for is depression. And depression has a lot of treatments, medications, therapy. TMS is another treatment that is non-invasive. It has few side effects, and depending on how you do it, it can be rapidly effective for depression. I mention it here because the next things will be more invasive, but TMS is non-invasive. It is being studied a little bit in Parkinson's disease specifically. It certainly works in people with both depression and Parkinson's disease, and it is being studied for the other symptoms of Parkinson's cognition as well. We can go to the next slide. Okay. So I talked about how medications can make cognitive symptoms worse, how lowering them can make it better. The bottom line is medically, there is not that much that we can do to improve cognition, which is why I spent most of the talk on non-medical interventions. DBS is a way of stimulating the brain to improve the movement symptoms of Parkinson's. For that, it works really well. It's not meant to improve the thinking in Parkinson's disease. It's not designed for that, and it doesn't do that on purpose, at least. In patients who have a lot of cognitive symptoms already, when their executive dysfunction has gotten severe or when there's Parkinson's disease dementia, DBS can improve movement symptoms, but it can make cognitive symptoms worse. But in patients who have kind of the normal cognitive profile of Parkinson's disease, and that means they have some executive dysfunction, they have some trouble switching from one task to another, but the kind that we see in kind of the broad cohort of Parkinson's patients, deep brain stimulation does not typically make executive dysfunction worse in those patients. The most common way that it affects cognition in Parkinson's is in verbal fluency, that is kind of finding that word on the tip of your tongue. And so this might come out if you ask someone to say, how many words can you list that begin with letter S in 1 minute? After DBS, that number might be a little bit smaller in kind of, the patients for whom it does have a negative effect on cognition. That's usually not something that's noticeable, as long as the patients who are getting DBS are not, don't have Parkinson's dementia, or at least don't have advanced executive dysfunction. We can go to next slide. The way that DBS can sometimes make cognition better is, I would say, almost as a side effect. And that is, it allows the lowering of medications. So if medications are causing impulsivity, if medications are causing, various compulsive behaviors, you can imagine that lowering medications can make those better, and DBS allows medications to be lowered. So in kind of a large review, medications were lowered by about 50%. Not every patient who gets DBS, the medications are lowered, but they can be lowered because DBS is kind of synergistic with the medicines. You can go up on one and go down on the other. And so, maybe you come off of the dopamine agonist, improve the impulsivity while keeping the motor symptoms under control. Now, like I said, for patients who already have more executive function problems, then we would be comfortable doing DBS, or we would at least give it a second look. Another option is focused ultrasound, which is a minimally invasive way of creating a lesion inside of the brain to treat the movement symptoms of Parkinson's. It's less invasive, but that's not really the point. The point is, it seems that maybe a little bit cognitively safer in patients who have more executive dysfunction. Part of that is that it's a newer treatment, and so maybe our data is not as complete as it is for DBS, but we tend to feel a little bit better about doing focused ultrasound in patients who have some more cognitive dysfunction issues. So it's another thing that's an option. Next slide. Which one of these is the right option for patients, or perhaps neither of them? That depends on patients' movement. It depends on their thinking. The cognitive changes in Parkinson's, they happen differently for everybody. Some people have a tremor for 25 years and very little other symptoms and very little cognitive dysfunction. And other patients, really the movement symptoms are not the main thing, and the cognitive symptoms are more important for them. We try to figure that out. If we're thinking about advanced therapies, we have everyone get a neuropsychological evaluation, which we often colloquially call a memory test, but that's not really what it is. It really is a way to assess what is that full spectrum of executive function issues and other issues to see is DBS safe? Is it the right thing? Is focused ultrasound better? Should we do something else instead? That's kind of how we figure out a way to individualize it to the cognitive function. And then finally, I said there's not much medically that really improves cognitive function in Parkinson's. A lot of the ways to improve it are non-medical, reducing medications, exercise. But Dr. McGilliner and I have a very active research program in trying to understand how to improve cognition in Parkinson's. We have found that the same parts of the brain that are involved in planning our movements and executing our movements, they are also the parts of the brain that are involved in decision-making and cognitive flexibility. And not surprisingly, when we stimulate them with DBS, we affect not just movement, but we affect cognition, and we're trying to figure out ways to make that smarter. Okay, so we can go to one more slide. To summarize, Parkinson's disease causes executive function issues. They are different for every person. They are not Alzheimer's disease. They're not the loss of memories or the loss of abilities. They're the loss in switching from one task to another task, primarily, and being flexible in what we are doing. Really the most effective way to improve the cognitive symptoms of Parkinson's disease is exercise, regular aerobic exercise as part of a program, whether that's cycling or boxing or PD on the move or dance. All of those are ways to do it. And whether DBS or focused ultrasound, how that plays in, which one is right for the right person depends on the cognitive symptoms as much as it does, if not more so, than on the motor symptoms of Parkinson's disease. And I will we'll leave it at that. I guess the question is, when do we take questions? Should we do it now, or does Dr. Morgillon want to come and?
Yeah, you want to take some questions now?
Yeah.
Okay.
Questions? Okay, well,
You don't know that what we introduced you earlier when you weren't here.
Yeah, well then.
okay.
So,
I'm really sorry I was late, crazy traffic, so, but,
we're glad you're here.
okay, well, happy to be here. So, I was Dr. London, who
I told him not to have
he
slides.
told me not to have slides, and so anyhow, we'll just talk a lot of the things. I will go into just an introduction. I was introduced. We're both neurosurgeons and specializing in treatments, advanced treatments for Parkinson's disease. We work as part of a big group that has really about 8 or 9 neurologists at NYU. One of them, Dr. Michael Wolf, couldn't make tonight, is really what's called a DBS neurologist, and he works directly with us. And I've been involved in surgery for Parkinson's disease now, studying young looking patients for 25 years or so. And I want to talk about the modern advanced therapies, which do include something that's been around for a long time, DBS and brain stimulation, as well as focused ultrasound, which you mentioned. And we can really say that's been around only about, really, real form 10 years or so. So if you do get to the point, right, what are these therapies for? Who are they for? Why? And it's already been mentioned. So the two of us really deal with patients that have had Parkinson's for a while, usually at least 3 or 4 years. One of the reasons that patients don't have these interventions earlier is because there are some diseases that start out looking like Parkinson's disease, and they're not really Parkinson's disease. So no one's really recommended to have any of these treatments that soon, because what if it's not Parkinson's disease? So usually by the time 3 or 4 years have gone by, we're really sure it's Parkinson's disease. And again, if you don't have it, if something else is not Parkinson's disease, we do the surgery, number one, it may not help you, and number two, there's a small chance it can make you worse, very unlikely. So the intervention, the treatment that's been around for a long time, and I'm sure you've all heard about it, is deep brain stimulation, DBS. The DBS involves an implantation, it's a surgical procedure. The best way to think about it, and we've said this for many years, is a pacemaker for the brain. So when you think about it, I like to modify that a little bit. There's something called a defibrillator. People have that because the heart shocks when it needs to. I think it's a combination of a pacemaker and a defibrillator. So when you have Parkinson's disease, as you all know, the ultimate cause is the absence or the depletion of chemical called dopamine. So the dopamine signal is not getting from one part of the brain to the other. It's not getting from point A to point B. And because it doesn't get to point B is not sending a message to point C, and point C is not sending a message to point D, and so on and so on. So the question is, and then because of that, people have all these symptoms. They have what's called negative symptoms. They can't move, they have shaking, and they're slow and stiff. So the idea of DBS right now is to do the following, is to say, okay, well, we know that down the road, part D of the brain is sending the wrong message now to part E. So what if we tell part D, stop sending the wrong message? So we turn it off. So we shock it away. And that's what DBS is doing. It's not giving us back the dopamine. There are other therapies, I'll mention at the end, that try to do that, besides medication. So the DBS is saying, okay, we know that down the road, A is sending the wrong message to B, B is sending the wrong message to C, C to D, and D to E. And when E gets the wrong message, it makes you shake, or it makes you move slow. So what if we told part D of the brain to stop sending the message and to send something else? So some people call it white noise. You know, this machine you turn on there is white noise. So it replaces the signal. Every part of the brain has to send the signal. So it replaces the regular abnormal signal with white noise. And because of that, the symptoms get a lot better. And who is it for? Okay, what are the symptoms that DBS treats? Tremors, slowness, stiffness, and something called dyskinesias. Dyskinesias, if you know what they are, you know what they are. So even though we're having them right now, there are side effects from the medicine where you move, and these extra movements. And you get them from the medicine because you need to take the medicine to move. And if you don't take the medicine, you can't move. So you get to a point where after a few years, usually, of medication working really well and being nice and steady, you'll fluctuate from being off to being on, and then to have severe dyskinesias. And some of them are so bad that people have difficulty walking and so on. So those are the basic 4 symptoms that it helps. What doesn't it help? Unfortunately, the one thing right now that hasn't been able to prove to help is people have very bad balance problems. And balance problems with the medicine. If someone comes to us and says, my walking is bad, well, DBS helps. So the first question we ask is, well, what happens when you take your medicine? Does the walking get better or not? If the person says, yeah, the walking gets better with the medicines, and then we'll say, okay, there's a chance that DBS will get walking better. They say, no, the medicine doesn't help the walking, then it's probably not going to get better. In general, DBS helps the symptoms the way the medicine does, but it helps it longer and more steadily. The one exception is tremor. DBS can help the tremor better than the medicines. So if someone has really bad tremor from Parkinson's and the medicine's not working, you would still consider DBS. It can actually be better than the medicine. For the other symptoms like the stiffness, the slowness, the DBS will be as good as the medicine. And for the dyskinesias, because usually you can lower your medicine after surgery, it'll make them better. And even if you can't lower your medicine, depending on how you do the DBS, it can also make them better. As Dr. London already mentioned, unfortunately, we don't have anything for cognition. It doesn't improve memory problems. And indeed, we study everyone carefully before surgery because there is evidence that if you already have significant issues with your memory that are not normally seen in someone in your age with Parkinson's, there's a chance it can get worse. So if, for instance, to pick one major example, if someone already has hallucinations from Parkinson's disease, and the hallucinations are part of it as opposed to like a side effect of medicine, we will not recommend the surgery. Because that means that there's already a problem, unfortunately, in the brain that suggests that surgery is not a good idea. And is there any, I'm just going through questions for you. Is there any age limit? For DBS, if you survey most of the world, most people will say that the early 80s, by then already we're worried we don't want to do the surgery. I have done, in my experience, DBS in people up to 82, 83, 84, and obviously it's a number. So there are people who are 60 years old or 50 years old who look like they're 80 and vice versa. So I won't say no, but when someone's really 85 would be probably no one would really be doing DBS, and then you're getting closer to the 9th decade of life, so to speak, in your late 70s, 80s, you have to be very careful. If you do a perfect surgery, and for some reason or another, you just don't do it as well. And again, in terms of the surgery itself, depending on how we do it, and also 1 or 2 night hospital stay, and everything is implanted. You have electrodes in the brain and a pacemaker in the chest, usually 2 or 3 different surgeries. Once that's done, you really won't need any surgeries, hopefully, for the rest of your life, except in about from anywhere from 10 to 15 years, an operation to change the pacemaker in your chest. That's very commonly done for people with heart pacemakers with no age limit. People with heart pacemakers have operations literally at age 100, so that's really surgery. One of the things about the DBS, as you know, Parkinson's patients do need to see a doctor regularly, so it is something that you have to commit to always following up with a doctor because you have to make sure the device is working okay and so on. If someone is going to go somewhere, without any medical follow-up, we wouldn't recommend it. And again, there are a lot of different things that I'm talking about, but that's just the general effect. So again, it's really, it is estimated that 1/4 of Parkinson's patients in this country would benefit from DBS. But when you look at the penetration, it's much less than that. And I think it has to do with a lot of uncertainties or lack of knowledge. When I started doing this, when I was a resident, it was 25 years ago, Like 8 years ago, it was sort of went backwards. What happened was that the doctors didn't know what to do, and they said, well, these patients, nothing can help, let's try DBS, because there's nothing else to do. And that was the wrong thing, because there were some patients that nothing would work for, and so on. And then over time, people realized who to do it for. In addition, there was a lot of, really, let's say, miscommunication about the risks. Now, since it is surgery, there are risks to doing it, but if you have it done in an excellent location with people who do it very well with low risk percentages, the chances that I always tell us, the chances of this surgery making you worse, what are the chances that you do the surgery and you say, I wish I didn't have the surgery. I wish I hadn't had done. Modern centers with modern technology, that would be about 1% or less. Now, you may say, I wish I had gotten everything better, got my tremor better, and got my stiffness better, and got my slowness better, I wish I got my walking better. That could happen. So we always want people to go in, with open eyes and say, this is what's going to help. It's going to help A, B, C, D, and E, but it won't help F or G. And if you really want that thing helped, then you might as well do the surgery. And that's really, now, in terms of getting the surgery or having you on your candidate, the best thing is to see a good neurologist, or a neurologist who knows about it. And then they'll say, okay, I think you're a candidate. And then depending on where that physician is, if they work with a team that does DBS, they'll send you to the surgeon. If not, I'll send you to another surgeon that does it. And in New York, we're blessed by many good institutions that have good, DBS teams. So that's the DBS. Now, the latest thing in the past 10 years or so, something else called focus ultrasound, which is a fantastic technology developed, and it's really the one device now is developed by a company in Israel. It was developed based on using it in other parts of the body where they found out that the ultrasound could actually turn off a part of the body, like make a lesion if someone has a tumor in your prostate or something, burn it out. Then they realized that you could actually make lesions in the brain. So 50, 60, 70 years ago, people used to actually burn holes in the brain to turn off the symptoms of Parkinson's disease. When DBS came around, people stopped doing that because they said there's a little bit more risk to that because you have to put a hole in the skull and so on. But now ultrasound, we do the same thing miraculously without making any cuts or holes. We do it in an MRI machine, a special MRI room. It takes about 3 hours. And what happens is we deliver energy through 1,000 different sensor transmitters located around the head. And once again, remember I spoke about that location A, B, C, D, F. We pick a location, depending on what symptoms we're treating. Let's call it location C, and the location T, let's say. And we heat it up. So in the MRI machine, we can actually watch a tiny part of the brain get hotter and hotter to a point where it just stops working. And we're examining the patient, and we're watching the tremors disappear. And that's the ultrasound. And we've been doing that now at our institution for about 9 years. And the one thing about it is that until about a year ago, it could only help tremors because we're only good at targeting one part of the brain. So if you only get tremors, great idea. If you get the other symptoms, then we really only recommend DBS. Now, in the past year or two, we at NYU are part of a multi-center study targeting another part of the brain called the PTT that treats the tremors, the rigidity, the stiffness, and the slowness, and the dyskinesias. And there's some papers that are literally just coming out now in the Lancet or the journals mentioning that the results are very good. One of the differences is you have to do it in 6 months between both sides of the brain and so on. And of course, like anything else, it's rather new. DBS, we have followed up for 30 years that shows that it still works. And focus ultrasound, we don't know yet, but it seems to work. So what's our general philosophy? It's like this. Someone comes to our office and says, I want treatment. I want ultrasound. I want DBS. So examine them together with the neurologist. What are your symptoms? How old are you? What do you want to get for it? Is there too much risk of surgery? And what's your age? So the one thing about ultrasound, you can actually treat people with no age limit. We've treated people up to 97 years old who walked out. So there's no limit on age for ultrasound. DBS, as I said, 80-ish, a little bit more. That's one of the issues. What if there are other medical reasons you can't have surgery of any type, anesthesia, you think about ultrasound. If your symptoms, again, are tremor mostly, ultrasound is reasonable. The one thing we do know about ultrasound, even though it is a great procedure, is that there's a higher recurrence rate. In other words, when you do DBS for tremor, when it works, it works basically down the road for 98, 99% of people all the time. For ultrasound, for some reason in Parkinson's, we're not sure why, in a year or two, there's about a quarter to a third chance the tremor comes back. We don't understand why. So if someone comes to our office and they're younger, in their 40s, 50s, 60s, we will still recommend DBS because we have a very long track record. We know what you're going to be like with the surgery in 10, 20, 30 years. If someone is 85, 90, or in their 80s, we would consider their focus ultrasound. And then you're in the middle, it's going to be, both may be right, both may be wrong. We will have people come to the office and say, I don't want the DBS, I want the ultrasound, can you do it? If you think it's right, it's right. But sometimes we'll give our advice. And some patients, some people, they're both good ideas. And the question is what to do. If you do the ultrasound, and let's say the tremor comes back, you can still do the DBS. So that's not, we've had a couple of patients over the years that didn't want DBS, did the ultrasound, worked well for a year, didn't have DBS, and tremor came back. If you do the DBS, it depends. You may or may not be able to do the ultrasound depending on what type of DBS you have and so on and so on. But I think the ultimate message is, number one, keep yourself as healthy as possible, as Dr. Levin said. Number two, make sure you're seeing good teams that manage Parkinson's disease. And number three, be aware of all the technological advancements. And the most important thing, again, is to speak to good doctors. We always find the best thing to do is to speak to a patient. We can go and we have interest in doing this stuff. That's what we do. But a patient can hear, if they want to hear about the surgery, we're happy to always connect you to patients to talk about it and to go over what it is, both DBS and ultrasound. And on that note, I think it would be a good time for questions for both of us. And again, thank you so much for inviting us to talk.